Current trends in the management of progressive myopia. Thank you so much for the TNOA committee for inviting me to give this talk. Of course, I gave the topic without even realizing what I was saying. So I'll tell you why. Why are we afraid of progressive myopia, or is it myopia progression? So progressive myopia is when myopia becomes degenerative myopia. That's not what we're going to talk about, even though I only gave the topic. We are going to talk about myopia progression. So why is all this fuss going on about myopia control? Because every 1 diopter increase in myopia increases the lifetime risk of myopic maculopathy, and then they have to go to Sriram, by 67%. Okay? So when do we call it progression? Well, the spherical equivalent needs to have increased by equal to more than minus 0.5 diopters per year. What about axial length? Everybody's talking axial length also. Well, before age 10, axial length growth in the emetropizing children is about 0.1 to 0.2 millimeter per year. How do you know this child is going to become myopic? Because then it starts becoming more than 0.2 millimeter per year. And progressing myopes typically as 0.3 millimeter or more per year. Then you call it progressing myopes. So the key message, if we can keep the myopia below -3 and axial length below 26 millimeter, this is a huge modifying factor for lifelong risk of visual impairment. And that is our goal. Okay? So you have to understand why this child is myopic. Is it genetics or is it environment? So when we talk of genetics, you have to pay attention to age of onset. How early did the child start wearing glasses? How rapidly is this progressing? And like, for example, these questions have to be asked to the mother or the father, and the father. What age did you start wearing glasses? How rapidly did your refractive error progress? And what was the final refractive error before it became stabilized or you had LASIK? Now, environment, you want to ask the child. How much time is outdoors versus indoors? They generally find children with higher IQ or pushing themselves to study, studying in ICSC, Cambridge board, international board, all these kids, they're more prone to myopia. Urban environment compared to rural environment, and continuous near work. We all used to say, oh, it's all the gadgets, it's all the phones, it's the iPad. No, kids who read good old books hours and hours together are also at risk. Okay, so what you need to do, myopia progression, we have to pay attention. Who is going to progress? Younger age at onset, strong family history, visual environment is terrible because their child never goes out. And then Asian ethnicity, and when I say Asian ethnicity is not really applicable to us, but maybe more in the northeast, people from West Bengal, where there may be some admixture to Asian ethnicity and binocular vision conditions. Okay, so what do we have? What interventions do we have to stop this progression? We can provide advice on environment that includes 2-hour outdoors, take breaks regularly while you're near work, elbow rule. Keep it a little far away, as far away as your elbow, from your elbow. Have important controls over smartphone use and good sleep. Sleep has also been shown, poor sleep has also been shown as an important factor for progression. What do we have for optical and pharmacological? Well, we have these myopia controlling spectacles and low dose atropine. And finally, if despite everything, if you are progressing, maybe look for binocular vision anomalies like esophoria or accommodative lag. Okay, so I'm going to illustrate this better with 2 patient examples, just to tell you how much chair time goes into myopia these days. Those days, you just fitted glasses. When my father was in ophthalmology practice, he just fitted glasses and just said, come back after a year. So, but this is just it's become so complex now. 8-year-old male child comes with parents, unable to see clearly with the current glasses, wearing myopic spectacle correction given by a local ophthalmologist for the last 2 years. Now, when they started, had difficulty in school copying from the board. Child is in good general health, non-consanguineous marriage, full term, normal delivery, cried soon after birth, normal milestones. Child looks a bit shy, parents look worried, and this is our dialogue. Do either of you wear spectacles now or used to wear in the past? Then the father says, I have never worn glasses, but my wife used to wear glasses, but then underwent LASIK. There's some genetics going on. So I said, what age did you start wearing specs and what was the number? And what was it when you had LASIK? She says, I started specs when I was 10. I started with -2. By the time I had LASIK, it was -5. How about your other children? Well, I have one older child, she's 12 and has started wearing glasses since 3 years, number is -3. So now I conclude from the history that this child has mild to moderate genetic predisposition with one parent, one sibling with myopia. Okay, now I go on to asking environmental history. How much outdoor time does he get per day? The child says 40 minutes of PT in school, twice a week. How about at home? What is the routine after school? Comes home by 3:30, has a wash, eats some tiffin, watches some TV, then goes for chess class. Chess is twice a week, then badminton twice a week. They're very proud. I've put the child in chess class, badminton class. Then from 5 he has Hindi tuition, then he will go down to play with other kids till 7:30. Then he will finish dinner, finish other homework and then go to bed. Okay, how much is phone, tab, iPad usage? Not much, but he loves to read. He will always be with a storybook. We have also encouraged him. At least no phone addiction, no. How is his sleep? Oh, he sleeps really well, 8 hours. So I conclude that he does not get much sunlight exposure, excessive near work in the form of books, but good sleep. I summarize the clinical exam. No esophoria, cycloplegic refraction has increased by -1.5. Objective, subjective, everything. Fundus is normal. So is this progression? Progression of myopic refractive error, remember, more than equal -0.5 is progression. Yes, this is progression. Significant progression. So what do we do now? I cannot change the genetic component. So I'm saying, what can I change in the environment? I don't ask them to bring photos of their house for every patient, but I ask them to describe their house. Do you have a window? Do you have a balcony? Do you have sunlight coming in? And this is what they describe to me about their house, that they also have a terrace. So my advice is like this. Morning breakfast is in the balcony. Take him out of chess and badminton because both are indoors. Put him in tennis, swimming or football. We can take him to park, beach or sit in terrace for 2 hours. Reduces book reading to maximum 30 minutes a day when school is in session. Monitor the distance. No lying down and reading. No phones. After 6 months they come back. Refraction is stable. So we have deferred starting other myopia interventions. Do I routinely order axial length before starting treatment? Usually I do, because I want 2 factors. I want something that the parents can see, because objective, subjective, everything is mine, the refraction. But I also want to see an axial length, which is a true objective measure as well. Okay, patient 2 and 3 came together. 8-year-old boy, 9-year-old girl, wearing myopic corrections for 3 years. Every year there is a change in the number. Good health, normal birth history. History of excessive smartphone use during COVID because they started online classes on the phone. Both children showed change of -1.5, -1.25, subjective, objective. Myopia history. Neither parents myopic, not grandparents, not uncles, aunts, cousins. I ask all this. How many kids, siblings do you have? I ask the parents. How many do you have? Do they wear glasses? Do their children wear glasses? Means first cousins. So this is how you have to take history now. So myopia history. I ask them environment. 2 PT periods per week, after school tuitions back to back. There is no place to play. Both parents work and return at 8 p.m. Grandparents watch the children. The children watch 2 hours of smartphone before parents show up, so that the grandparents can watch TV. There is no question of a smart TV. Because sometimes I'll tell them, project it in a smart TV. No, at least they're not sitting with the gadgets. This is their house. Where will they play? Where is the window? Where is the balcony? There is nothing. So my advice is like this. There seems to be no genetic predisposition. I understand that both of you work and it is difficult to expect grandparents to take the children out. I also realize there is no place for the kids to play. But let me explain about the environmental modification. So I tell them a few things about reducing smartphone use, all those things. But I will explain myopia control glasses versus LDA. These parents heard the cost of LDA and they said, no, we will, and the cost of myopia control glasses, they said, no, we'll go with LDA. Okay. So that is what they did. After 6 months, both children's refraction changed, this time only by -0.5, because it's not magic. It will slow the progression, eventually stop. The mobile phone users cut down to 1 hour with breaks. They go out for 2 hours on Saturdays and Sundays when the parents are off from work. In conclusion, evaluate how much genetic vulnerability this child has for onset and progression. Capture the child's daily life. Then design the child's daily life. Don't tell them, take him, let him have outdoor for 2 hours. Where will the grandparents take them for 2 hours outdoors? So what we call as motta advice. Don't give motta advice. Design the child's day. Understand the family's challenges in implementing your environmental advice. Judicious choice of myopia control options, close monitoring with open lines of communication between you or your assistant and the family. Thank you so much and good luck.
Thank you so much, ma'am.
Brilliant talk.
The permission of the chair, if I can use this term, your talk was in Vera level, in Tamil.
Yeah.
So, ma'am, I just saw one slide where you said LDA versus myopic control spectacles. So, not that I don't know, living as a pediatric ophthalmologist, I know that there are two different modalities.
Yeah.
And they have definite cutoffs.
Yeah.
You do LDA only in certain age group and certain refractive ranges. Same with myopic spectacles. But of late we see any child, or rather probably not even child, sometimes I even see adults who've been diagnosed to have myopia, who are prescribed LDA and whatever one of those myopic glasses which you talk about. This is very, very disturbing and growing trend of late. I'm sorry.
Right. So I absolutely right. I have parents who have come urgently back 2 days later after my suggesting regular spectacles with environmental modification. Because my worry is if I only give the LDA as the first choice, or the myopia control spectacles as the first choice, or LDA, the environmental modification never happen. So, and we know how powerful the sunlight exposure is in curtailing myopia or slowing the progression. So I never, unless they show clear evidence of progression over the last many visits to some other ophthalmologist. They have clear progression. Then I say, okay, let's start LDA. Otherwise, so I've had parents who will come running back 2 days later. Madam, we went to optical shop. They're told apparently there are special glasses. You didn't even suggest. Looking at you like don't have any knowledge. How come we came to you? Optical shop liye solran. Enna madam neenga sollama vittutinga. You hear all kinds of nightmares.
True.
Okay. So
That's why I asked that.
Yes, absolutely. You're absolutely right. Or people who come with everything. Avial. Put this also, that also. Or panacea for all refractive errors. Plus, minus 0.5 cylinder, a patient is wearing LDA. Okay, anything goes. So, and as an educator, it always goes back to me and my guilt, and I feel, Urunga soliye tarla. We didn't teach them pediatric we didn't teach them how to manage myopia.
Yeah.
We didn't teach them ophthalmology. We didn't tell, because most of myopia is managed by non-pediatric ophthalmologists. Pediatric ophthalmology hopefully know how to give and what stages to give and all. But the bulk is by non-pediatric ophthalmologists. Right? Myopia should not become pediatric ophthalmology. Ayyo, na adha already paakren. I want to see a few squints here and there. I see only myopia. So I am happy for others to please manage myopia, but solliye kudukalappa. How to do refraction.
Like it's always a potpourri where patient has LDA. I've seen 20-year-olds with LDA and myosmart glasses, and problem is, we have to cut a sorry figure because we don't know what to tell them at all.
But
Why are these
Meenakshi, I want to ask
so
you.
expensive?
Pardon?
Glasses
Yeah.
These myopia glasses are so expensive.
And how effective it is?
That is the technique. It is effective.
Really
It
effective?
is effective. It is effective. But again, it's not a standalone. If you give
No,
the
you
glasses
take
and
the
they are
other
they are
factors also.
Yeah, exactly. Because like I said, I think the environmental modification is a lifestyle change. You need to bring in that lifestyle change and put these things as it cannot be used as a crutch. Now, the potent Kannadi, I'll do anything I want. That cannot be. Ni iPad parra 4 mannero cannot be the answer.
What is important is the range of refraction and the age of the patient.
Age of the patient, range of refraction,
Any
affordability.
questions from them?
Yeah.
Any questions? Yes, ma'am. Can you use the mic, madam?
Sometimes the patients with the hypermetropia,
Hey, careful.
they also
somebody
come,
please help
they
them.
also come and they will say कि पर हमारे बाजू में जो रहते हैं उनको कुछ चश्मे का नंबर कम करने के लिए कुछ दिया हुआ है. Then you have to explain that
yeah.
it is your plus lens, because for them it is only a glass.
Glass.
Glass, yeah.
So you have to have a good chair time